Good morning. Here we are presented with a 7-year-old boy with supracondylar fracture of humerus, posted for open reduction internal fixation with K-wire fixation. The message we want to deliver through this video is that nitrous and volatile anesthetics must be avoided in any case whenever possible. After a thorough pre-anesthetic checkup, patient was cleared for surgery and was planned for general anesthesia with a supraclavicular block. Inside the operating theatre, patient was pre-oxygenated with 100% oxygen, IV drip was connected and induction was started with propofol. After pre-medicating the patient with glycopyrrolate 0.1 mg, midazolam 0.5 mg and ketamine 10 mg. Patient was ventilated and injection atracurium 15 mg was given. After 4 minutes, direct laryngoscopy was done and airway was secured with an uncuffed endotracheal tube of 6 mm internal diameter by removing the cuff of a normal cuff tube. As you can see, the airway has been secured and the patient was connected to the anesthetic circuit. Bilateral air entry was confirmed by auscultation. The EtCO2 graph was confirmed and the endotracheal tube is being fixed at 16 centimeters. The maintenance of anesthesia will be started using infusion of propofol at the rate of 12 ml per hour according to the patient's weight. The ventilator was set to controlled PCV mode and the patient will now be positioned for a supraclavicular block with head turned to opposite side and the shoulder lowered. The elbow was already flexed over the abdomen due to the cast, and proper positioning of this patient for supraclavicular block is of utmost importance, and the operator stands on the side where the block is to be performed. As you can see, supraclavicular block is one of the several techniques used to anesthetize and to manage pain. It is performed at the level of brachial plexus trunks, where almost the entire sensory, motor and sympathetic innervation of upper extremity is carried. The indications of this block are elbow, forearm and hand surgeries. We are using an ultrasound for visualization of the nerve plexus. And with the patient in proper position, the skin was disinfected and the transducer positioned in the transverse plane immediately proximal to the clavicle. The subclavian artery crosses over the first rib between insertions of anterior and middle scalene muscles. The subclavian artery, as you can see in this video, was seen as an anechoic structure on the ultrasound, whereas the pleura and the first rib are seen as linear hyperechoic structures immediately deep to the artery. The brachial plexus is seen at a depth of about 1 to 2 centimeters as a bundle of hypoechoic round nodules like a bunch of grapes, just posterior and superficial to the artery. The upper, middle and lower trunks were identified by adjusting the transducer position. The needle was then advanced in a plane towards the brachial plexus in lateral to medial direction. 2 separate injections are required for adequate nerve block. The insertion of needle into the sheath is often appreciated as a pop. After careful aspiration, 1 to 2 ml of anesthetic was injected to confirm needle placement, and we can see that the injection displaces the brachial plexus away from the needle. We used injection bupivacaine 0.5% 5 ml diluted with injection loxicard plus ADR 5 ml and a total volume of 10 ml was used. The benefits of using ultrasound for visualization is that it improves the monitoring of anatomy and needle placement. Other benefits in pediatric age group is that precise lower doses of local anesthetic can be used. The procedure was started and the patient remained hemodynamically stable throughout intraoperatively. As we can see that the patient was taken on total intravenous anesthesia by using infusion propofol, and we are using oxygen plus air to deliver flows. So we should avoid nitrous oxide and halogenated agents due to its hazardous effects whenever possible. Thank you very much.